Welcome back to the Ninja Nerd Podcast. Today we're talking about IV fluids. We're going to take a case, analyze the fluid management of that case, and go through each one step by step.
Fluids are good, right?
Fluids are so good. They're pretty helpful, right?
They are helpful.
But you don't like fluids, though.
I'm picky.
Why are you picky?
I'm picky because I think like a lot of the times we volume overload our patients iatrogenically. So I think that sometimes it's important to know with fluids how much to give, when to stop giving them, and just have an indication as to why you're giving them.
Yeah.
As like anything, it's a medication and it comes with risks. And I think it's really, really important for us to know when to give them, how much to give them, and just when to stop.
Cool. It makes sense. I guess if you don't have a reason for doing something, it's not good.
Yeah, it's not a good reason. You should always have an indication as to why you're doing something and then kind of what you're aiming for. And so hopefully, I think after we talk about this episode, I think we'll have a better idea as clinicians on how to really kind of think about fluid management.
All right. Let's go through this case here and kind of work our way through it, and we'll ask questions as we go.
Okay.
So we have a 65-year-old woman presents to the ED with fatigue, dizziness, and decreased urine output over the past 2 days. The patient reports a significant decrease in her urine output, feeling lightheaded when standing, and general fatigue. She endorses vomiting and diarrhea, but has no recent changes in her medications. The patient mentions that she has been having difficulty staying hydrated due to a poor appetite and an increased work demand. She denies chest pain, palpitations, or shortness of breath. For her past medical history, she's a type 2 diabetic. She has hypertension. She is a stage 3B CKD, and she has hyperlipidemia. Just for a quick recap, how do we determine a CKD stage 3B?
GFR. So usually like a GFR, if it's like 30 to 44, that falls in that range of CKD 3B.
So good review there.
Yeah.
Her medications is metformin, lisinopril, amlodipine, atorvastatin, and insulin. For her exam, we take her vitals. We have a BP of 88/60. That's not good.
No, she did.
She's not perfusing anything.
No, it's not good.
Heart rate's up. It's 110. Respirations is 18. And her temp is 97.7. O2 sat's 98% room air. She appears lethargic and dehydrated. She is clear to auscultation bilaterally, soft, non-tender. And for neuro, she's alert but sluggish responses, oriented to person and place, mild orthostatic hypotension. For her skin, it's dry mucous membranes, poor skin turgor. We do some lab work. We get back the following. Creatinine of 3.8. That's up from a baseline of 2.5.
Okay.
BUN is 70. Hemoglobin, 10.8. Potassium is 5.2. Sodium is 133. Phosphate, 4.2. Calcium of 8.8. Albumin, 3.0. GFR of 22. That's not good.
No, call the morgue.
Oh, no.
I'm just kidding.
Serum lactate of 4.2, and her urine output is 150 mils over the past 12 hours. So she really is not urinating at all.
No, not much.
Well, I have questions.
Okay, hit me.
Do you have answers?
I hope so.
All right, let's find out. So, based upon all that information, does the patient need fluid resuscitation currently using fluid boluses? And if so, why?
All right, cool. So that's definitely a question I think I can answer in the sense that this patient looks very ill. Right away, there's hypotension, right? And so then you start thinking about, okay, is there evidence of shock? That definitely seems like there's evidence of shock too. There's elevated lactate, so there's poor organ perfusion. So 4.2, that's definitely a little bit elevated. On top of that, creatinine bumped, urine output down, so the kidneys aren't getting perfused. And then on top of that, she's probably not perfusing her brain very well as well. And so I can tell that by the fact that they're alert but sluggish responses. And so that seems like there's maybe a little bit of an altered mentation. So poor perfusion to organs. So this is definitely shock. Second thing is, what kind of shock? There's always different types, right? But I think with the history, it suggests that they're vomiting, diarrhea, and then not taking in enough fluid and fluids. So this seems like hypovolemic shock. Other things to think about with hypovolemic shock is the way that they look on exam. They appear dehydrated, it says. They're tachycardic, which is a compensatory response to the hypotension. And then on top of that, they have dry mucous membranes, poor skin turgor. That definitely makes me think hypovolemic shock.
My God, this is this is so simple. Just pump her with fluid,
Yeah.
right?
Yeah. It really would be.
Come on,
It's just
like,
you
it's-
have to
just
know
pump it.
how much.
Throw just as much as you
Just
can.
17 liters in about a couple minutes.
Just as much as humanly possible. No,
Just all of a sudden. Whoof.
this is why I'm
like a
not the
puffer
provider.
fish.
This is why he's the provider.
No, I would say that this patient definitely needs fluids. I'd probably start off giving like a liter, maybe 2 liters of fluids. I'd start off with an isotonic like crystalloid, maybe something like normal saline or lactated ringers. I'd give a liter. I just would be careful. The reason why I'd be careful, I'd start off with liter is this patient has CKD, so they can retain a little bit of fluid.
Okay.
But I'd probably give a liter, maybe 2 liters. And my main goal is I'm giving fluid to improve the blood pressure. As a response of improving the blood pressure, I hope that the organ perfusion starts to improve. The tachycardia starts to subside, the mucous membrane, the foreskin turgor starts to improve, urine output starts to increase, lactate starts to decrease, and then mentation starts to improve. So that's what I would give fluid boluses for. I'd start off with 1 liter, maybe do that over 30 minutes. Then I'd give another liter if I'm still not getting that blood pressure or those kind of perfusion parameters I'm looking for, see how they're looking after that. So that's kind of the way that I would start this off, really trying to get them to become more hemodynamically stable.
All right. Well, let's say after we do this, we get her blood pressure up to 105 over 70.
Okay.
It's looking like things are improving. How do you know, basically, what tests do you do to say the amount of fluids we gave is good and we don't have to give any more? Or do you say, do I need to keep doing fluid resuscitation?
That's always the hardest thing to determine. There's no perfect test to see when a patient needs more fluid or if they don't need any more fluid.
Okay.
There is different tests that we try to look at. I think it always involves looking at the underlying history, looking at the physical exam. Doing cardiopulmonary ultrasound is also another one as well. But there is a couple tests that we've utilized, and you'll find this in a lot of like intensive care medicine books, where what we'll do is we'll do 2. It's an alternative. It's the same thing. One is you can do a passive leg raise. I like this test, and what you'll do is you'll kind of lift the legs of the patient up to about 45 degrees. Now, it's interesting because we probably hold anywhere from 250 to 500 milliliters of blood in our lower legs at any moment. If you lift their legs, you shift that 250 to 500 mLs towards their right atrium. And then you can utilize that blood as a preload, increase your stroke volume, increase your cardiac output, your blood pressure, and perfuse organs.
So you're giving fluids without actually giving fluids.
Exactly.
Huh.
That's the beauty of doing
neat.
this
That's
test,
cool.
is that you don't run the risk of overloading them. And so what you'll do is you'll do the passive leg raise and you'll have some type of parameter. That's the hardest part about this, is you need to have a way of measuring their stroke volume or their cardiac output. And we don't have a lot of great ways of doing that. You can try and use like echocardiogram. You can try and use like a Swan-Ganz catheter.
Mm-hmm.
But oh, dear Lord, if we're doing that for every hypovolemic patient, we're not having a good standard of care. You also can use all these like non-invasive methods where they put like these, it's called a cheetah, and they put like these bioimpedance pads on their chest, and it kind of gives you a graph to see where their stroke volume and cardiac output is. You can do these things called NICOMs where they look at pulse pressure variation. But either way, all we're looking for is when I do that passive leg raise, does the stroke volume or the cardiac output increase by greater than or equal to 10 to 15%? If it does, that means that they responded to the fluid and they need more. All right. So that's one way we look at it. Another one is like their stroke volume variation, which looks at the variation in stroke volume between these time frames. And if that is like very variable, if it's greater than 12%, usually, that tells me that there's a lot of variation and this patient probably needs more fluid. So stroke volume variation greater than 12%, responding to the actual passive leg raise and cardiac output goes up by 10 to 15%, they're responding. Blood pressure improves, urine output improves. Those are all indications to say, okay, I can go ahead and give a little bit more fluid. So maybe I'll try another 500 milliliter bolus or another 250 bolus. And so I'll just keep going and keep giving fluid until I notice at some point, is the cardiac output and the stroke volume not increasing anymore? Oh, it's not? Okay, that's weird. Is the stroke volume variation not really variating much anymore? Is it less than 12%? Is my urine output not really making much of a difference anymore? If that's the case, and now the central venous pressure is going up, they're starting to get a little bit volume overloaded, I have to cut back. I have to say, okay, too much. Stop giving fluid boluses, no more. So that's the way that we have to look at these things, is very carefully have ways of monitoring a patient's stroke volume and cardiac output. And by doing that, they're doing the passive leg raise. to see, is it improving? At any point, is that passive leg raise not improving, or is the fluid that I'm giving them not improving the stroke volume, cardiac output, their urine output, their stroke volume variation? If it's not, and they're starting to get volume overloaded, they have pulmonary edema, pleural effusions, their weight's starting to go up, I got to stop, pull back on the fluids. No more fluid
So
boluses.
this really doesn't have to be a gray area like you think it would. There
It
is
doesn't have
ways
to
of
be.
interpreting them.
Exactly. I think what happens a lot of the time is that we do the alternative. And so instead of doing a passive leg raise, what we may do is we may give a patient 500 milliliters of fluid. And when you give them that 500 milliliters of fluid, you monitor, they had an increase in their stroke volume, cardiac output, their stroke volume variations less than, it's greater than 12%. So let's give them a little bit more. And they keep doing that and doing that and doing that. What can happen is if you're only following those parameters, it's not perfect. That's not great. You need to also be following their exam. Does the patient look like their weight's going up? Is their I&O balance going up? Is their lungs starting to sound like they have crackles on auscultation? If those things are happening, I'm not getting much of a benefit and I need to pull back. And so usually most people, if I give a liter of fluid, our circulating blood volume is 5 liters. If I give 5 liters of fluid, I'm giving essentially my entire circulating blood volume. And out of that 1 liter that I give, only 250 milliliters stays in the vascular
They're
system.
gonna roll out of that room.
Yeah, exactly. So
Yeah,
that's
balloon.
why it's really important to just know, hey, I have a lot of different ways that I need to monitor cardiac output. I think the best way is urine output, looking at their perfusion, looking at how well they're perfusing their skin. So does their skin perfusion start to improve? Looking at their mentation, looking at their lactate levels, and then utilizing focused ultrasound. Is their left ventricle squeezing very good and getting all the blood out? Are their lungs filled with fluid? Oh, they're not? Okay. If they're still responding and their stroke volume's going up and their stroke volume variation is still pretty high, keep giving them a little bit of fluid, but just keep a close eye on them is the key.
So how do you determine how about this? What do you do if a patient is fluid responsive or if a patient is not fluid responsive?
So let's say that I did that passive leg raise, right? Did that, stroke volume went up, cardiac output went up by 10 to 15%, stroke volume variations greater than 12%, urine output improved, lactate's starting to go down, and they're not getting volume overloaded. They look like their lungs are clear, their heart's working well. I'll give them another bolus. So I'll give another 250 to 500 milliliter bolus. Give them a little bit of time, see if they're still responding well. If I give them that bolus, or if I do another passive leg raise, are they showing any signs of fluid responsiveness? If they are, give them another bolus. If they do not show signs of fluid responsiveness, you don't bolus. You don't give them any more fluids. You stop. Stop the fluid boluses. Stop the madness. Don't turn these people into Michelin men. So that's what you want to look for, is just keep a close eye on that. If they're not getting fluid responsive, or if they're not responding to the fluid, their central venous pressure is going up, they're starting to get pulmonary edema, their weight's going up, their eyes and nose are going up, and they just look like they're starting to move to the other side to volume overload, no more fluid boluses. Stop.
If the patient is adequately resuscitated
Okay.
and is not fluid responsive, but is getting negative on eyes and O's and can't keep up with the insensible and GI losses, what do you do?
That's a different story. So now, if I had this patient come in, right, they're hypotensive, I give them 1 to 2 liters. Cool. I improve their blood pressure, I improve a lot of their perfusion. Then from there, I do a passive leg raise to see if they need any more fluid boluses. As we did, let's say that she improved, stroke volume, cardiac output went up, stroke volume variations high, urine output's improving. Okay, I'll give another bolus. Okay. Let's say that after I do that, I do another fluid responsiveness test, no response. But she's still vomiting, still having diarrhea, having fevers, or she's not taking in enough. That's another story. Then I can say, okay, if she's fluid responsive, but she can't drink or eat enough to keep up with how much she's putting out, then I need to give her maintenance fluids.
Gotcha.
And that's where I would use something like a maintenance fluid. For this patient, I'd probably put them on something like lactated ringers or normal saline. Half normal saline, I'd be a little bit careful with, but in this patient, I would even potentially consider like a half normal saline. Usually the most common maintenance fluid is usually going to be one of those 3: normal saline, lactated ringers, or half normal saline. So that's what I would do, is I would start this patient on some type of maintenance fluid.
Is there a preferred maintenance fluid like that is pretty common across all institutions?
It's not always a standard thing. So for example, let's say that I have a patient who has hyponatremia. I probably wouldn't give them half normal saline. I'd probably give them, normal saline. If a patient has hyperkalemia or like a metabolic acidosis, I'd probably give them lactated ringers. If a patient has hypernatremia, then I may give them half normal saline.
So it's just dependent upon the patient.
Yeah, exactly. Depends upon their volume status, and also, I say to some degree, primarily depends upon their electrolyte balances. That's kind of the way that I would look at that.
Do you know how to figure out a starting rate for the maintenance fluid?
Yeah, it's not a perfect science, but there is something called the Holiday-Seeger formula. It's what they describe for pediatric patients who need fluids. And it's the 4-2-1 rule, which you say that for every 4 milliliters per kilogram, that would account for, you'll give 4 milliliters per kilogram of fluid for the first 10 kilograms of that patient's weight. Then you give 2 milliliters per kilogram for the next 10 kilograms of their weight, and then 1 milliliter per kilogram for all the remaining weight. I don't like that. The easiest way is the rule of thumb is you just take their weight in kilograms and add 40.
Yeah.
So let's say that this patient is 70 kilograms, let's just say. It's 70 kilograms plus 40, 110 milliliters per hour is what I'll put them on. So I'd probably put this patient on maybe half normal saline if their sodium's a little bit high because they're dehydrated. And I would put them on that. And I'd even probably add in a little bit of potassium, maybe a little bit of D5 if they're not eating. And then I would put it at about 110 milliliters per hour. And I would run that and just keep an eye on their eyes and nose. And what I mean is the patient starting to eat more, drink more? Is there less vomiting, less diarrhea? Are they starting to able to eat and drink on their own? If they can, I can cut those maintenance fluids. But the only thing I will say that you have to be careful is this weight plus 40 rule or the Holiday-Seeger formula. That's not standard for every patient. Okay. You have to be considerate of the patient's underlying disease. Right. If a patient has CHF and they have an ejection fraction of 20%, do not give them 110 milliliters of fluid an hour. If they have severe CKD, if they have cirrhosis, if they have something like that, you want to decrease that rate a little bit. There's no set number. It's kind of a Zen thing. You have to start getting a little bit used to that. But for example, if I had a patient who came in, they had severe CHF, and I needed to give them fluids because they were a little bit dehydrated, I wouldn't give 110. I may drop it down to like 75. So I may cut it in half or do something like that, similar to that. So that's kind of the way I would look at this, is use that rate. But again, if a patient has an underlying fluid retention related disease, severe end-stage renal disease, CHF, maybe cut it a little bit. If they're having terrible fevers or burns, you can't account for those insensible losses. You may have to give them a little bit more.
Yeah.
So those are things that you have to consider. It's not a perfect number. If they have insensible losses that you can't account for, maybe give them a little bit more. But if they have diseases that make them at risk for volume overload, maybe decrease that.
So like you mentioned before, if the patient's able to start to tolerate an oral intake, we can kind of stop the maintenance fluids.
Yeah, so that's what I would say. I'd say if we either have to get enteral access for them, let's say that they're altered for whatever reason, we got to get an NG tube in, whatever it is, so we have to start feeding them. Once I start feeding them and I get the rate of their feeds or how much they're eating and drinking close to how much they're putting out from diarrhea, vomiting, or that's starting to resolve, then I don't need to give them fluids anymore, because I was just giving them fluids to maintain their inputs in comparison to their outputs. But if they're able to drink or eat a lot of this and I'm keeping an eye on their eyes and nose are about the same, or how much they're taking in is about the same, I'm good. I can cut the fluids. I don't need to give it to them anymore.
So what's the biggest things that you have to monitor? If you had to say these are the biggest things that you have to be considerate of when giving IV fluids, what are they?
First thing is volume overload. So I want to keep a very, very close eye on any evidence of swelling in their legs. Are they starting to get like pitting edema? Is their weight starting to go up? Is their blood pressure starting to shoot up? Because that might be a sign of volume overload. Are they having shortness of breath? Is their oxygen requirements going up? Is they have crackles or rails on auscultation, signs of pulmonary edema? So those are things I would definitely be watching out for, because that tells me that they're getting volume overloaded and I need to stop giving them fluids. The other thing with fluids is if you give normal saline, you can risk hypernatremia. So be careful with that. I keep a close eye on their sodium. With normal saline, you can also cause hyperkalemia, so keep a close eye on their potassium. And with normal saline, you can also cause a metabolic acidosis. So I keep a close eye on their bicarbonate chloride. Lactated ringers, there's not many risk with that one. It's a pretty good drug. Be careful if they have liver failure, because if you're trending lactate levels, they can't clear the lactate as well, so it may be falsely elevated. And with half normal saline, be very careful with hyponatremia. So if you have it going too fast or too much, you can cause them to develop hyponatremia. So those are the things I would say. And the last thing is just remember, why are you giving this? It's to improve their blood pressure. So keep an eye on their blood pressure. Is it improving? Keep an eye on their renal function. Is their kidney function improving? Are they making good urine? if they're making good urine and they're taking everything that I'm giving them and putting it out, that's a good sign. I can probably keep giving them fluids if they're truly dehydrated. But if I'm giving a patient 1 liter and they're only making 10 milliliters of urine, something's not right. And you have to say, maybe I shouldn't give them another 14 liters of fluid. So just be cognizant of those things is what I would say.
All right. Well, that's really all we had for the IV fluids. I think that made sense. You kind of summarized all the key points, and don't fluid overload someone.
Exactly. Just know when to give fluids, know why you give them, and just be careful. Know how much you should be giving and when to stop. When you should just encourage them to drink or eat things on their own is the key thing.
Cool. It was awesome.
Thanks, man. Well, Ninjas, I hope that you guys also liked it. I hope that you enjoyed it. And I love you. Thank you. And as always, until next time.